Thank you for being here tonight. Welcome to Beyond the Guidelines. This is Clinical Investigator Perspectives on the Management of Prostate Cancer. This is part one of our two-part series for GU ASCO. I think, as you all know, there's a lot of good data, exciting data that was presented today, and we're going to get into hopefully some very engaging conversations about how we think about this data and how it's going to be applied to daily practice. Oops. All right, our faculty tonight, just go down the line here. We have Dr. Agarwal from Huntsman Cancer Institute. I think, very well known in the field, hardly requires an introduction. He's the chair of cancer research and director of the Cancer Investigational Therapeutics. We have Dr. Oliver Sarter. Dr. Sarter, of course, has been someone we've all looked up to for many years, a Laborde Professor of Cancer Research at Tulane. Next to him, of course, Misha Beltran. Dr. Beltran is now at the Dana-Farber Cancer Institute, the Lank Center for Genitourinary Oncology, and the Director of Translational Research there. And then, of course, at the end, Dr. Fred Saad, Professor and Chairman of Urology at the Raymond Garneau Chair in Prostate Cancer at the University of Montreal. A reminder, tomorrow night is the second part in the series where we'll do the Beyond the Guidelines on the management of bladder cancer. The moderator for that will be Dr. Monty Paul, and his faculty is there on that slide. For those of you in the meeting room, you've got the iPads there in front of you. You can use those iPads to review the slides. Also, you can answer survey questions within them. There was a pre-meeting survey that you might have seen, and we'll be talking about those questions throughout. You can ask questions on that iPad. Just tap the Ask a Question button to submit a challenging case or question for discussion. And as much as possible, try to incorporate some of those into the meeting today. And then don't forget to complete your evaluation with the CME evaluation button so that you can get credit for attending tonight. For those of you attending via Zoom, again, you can review the program slides with a link that will be posted in the chat room at the start of the program. You may see it already. You can answer survey questions there, also submit questions. And again, don't forget to fill out the survey at the end to get your CME credit. This is, of course, an enduring program, so everything that's being discussed tonight will be available online via video. The live meeting is being recorded via video and audio, and the proceedings will be edited and developed into a web-based program and PowerPoint program. All of you will receive an email link when that activity is available. And of course, you can always go to researchtopractice.com to find more content, both this and other programs. All right, so we will get started. Again, this is the Beyond the Guidelines Perspectives on the Management of Prostate Cancer. The agenda for this evening, we have 5 different modules. Each of the presenters will be talking for 10 minutes on their module, and then we'll have about a 13-minute session reviewing some of the pre-meeting survey questions, which are really meant to highlight some key decision points in the management of prostate cancer and hopefully stimulate discussions about how the panelists kind of reach their decisions and go beyond just the standard recommendations that I think we're all used to. These are the survey respondents. So for the questions that we're going to be discussing, these are the people who participated in answering those questions. Obviously, everybody on the list is a recognized thought leader in prostate cancer, very familiar with the data, and represent a diversity of perspectives, to be sure. All right, so module 1, we will start with Dr. Saad.
Thank you for the opportunity. I don't know if this is working, but yeah, okay. So thank you for the opportunity to present. So this is really ambitious in 10 minutes to discuss the optimal use of hormonal therapy in both non-metastatic and metastatic hormone-sensitive prostate cancer. Change the slides. Oh, there. Okay. So these are my disclosures. So the prostate cancer landscape, this is a simplified view that I use often to describe the landscape of prostate cancer. And as we all know in this room, no need to go over the importance of the different states. But if we look at ADT to start with, obviously many of the states or the states that are going to lead to the most of the morbidity and all of the mortality transition through the use of ADT. And just one slide on what's new in ADT, because there hasn't been much new in ADT over the last 30, 40 years, is an oral antagonist, relugolix, that showed a primary endpoint of sustained castration being not only non-inferior to leuprolide, but actually superior to leuprolide. And this is through the whole 48 weeks of treatment. And of interest, and probably the reason why this paper was accepted in the New England Journal was the finding that major adverse cardiovascular events were reduced in patients on relugolix compared to leuprolide, especially in the patients that had a recent history of MACE. So going on after ADT in patients who become metastatic CRPC, and we now have several treatment options to be able to prolong life and maintain quality of life in these patients. But unfortunately, the improvements are still modest in 2.5 to 4.5 months. And this is the reason why we need to try to introduce effective therapies early. So non-metastatic CRPC, if we start, this is based on conventional imaging. And we would all agree that these patients are probably micrometastatic. And we have 3 trials, phase 3 trials, that have all shown that we're significantly delay the appearance of visible metastases in high-risk patients, defined as doubling times less than 10 months. We also, importantly, and I stress this part of the analyses that are often overlooked, is that we delay resistance much longer when we introduce therapy in the micrometastatic state. So really the thought of earlier being better, much longer than when we wait for visible metastases to appear, where oftentimes PSA progression occurs within a year. Here, we're more in the range of 3 years before resistance sets in. And this actually turned out to be a very impressive improvement in overall survival, even though these 3 trials had all the opportunity in the world for the placebo arms to introduce early aggressive therapies and actually make any chance of survival disappear. It was actually 2 to 3 times greater median advantage in overall survival than the 4 months that we saw when we wait for mCRPC. So really, the thought that earlier is better, I think, is substantiated by these trials. Fortunately, quality of life was maintained in all 3 trials. Now, going to the hormone-sensitive metastatic setting, regardless of whether you are de novo metastatic or progressed to metastatic, the important message, I think, to take home is ADT alone is clearly no longer an acceptable modality for almost every patient. And why I say that is we look at the natural history of patients on ADT alone, and resistance sets in less than a year. And this is repeated in almost every study when you look at the ADT alone arm. And survival, even though you have subsequent therapies for mCRPC, are still dismal in 3.5 years survival in an all-comer population that was in Stampede. So can we do better? Definitely yes. The first with docetaxel showing that in high volume disease, you have a very significant advantage in improving overall survival patients with high volume metastatic disease that are still hormone sensitive. Titan showed very similar results with apalutamide in an all-comer population, both low volume, high volume, both de novo and metachronous, both in terms of progression-free survival and overall survival, with risk reductions of death very impressive, over 30%, in the range of 35% reduction. Enzalutamide, and this is repeated, so it might look like repetition, but this is very reassuring that it's a constant finding that we're able to significantly improve both progression-free survival and overall survival with these novel hormonal therapies. The updated enzalutamide study with ARCHES also showed that with time, this overall survival was improved with a reduction in the risk of death of 34%. And I added at the bottom, whether you were low volume or high volume, you had a clear advantage that favored giving upfront enzalutamide while patients were still castration sensitive. So the question, we have multiple options that include docetaxel and hormonally based therapies. And so how do they compare? And so it's hard to look at cross-trial comparisons, but look at the survival curves with docetaxel plus standard of care in the STAMPEDE. And STAMPEDE was recruiting at the same time to another arm that was abiraterone plus standard of care therapy. And you look, the hazard ratios are very similar, at least the first analysis, but you look over time that you're losing the advantage in overall survival as time progresses with the docetaxel, whereas in the hormonally based therapies, and this is in every trial with hormonally based therapies, the curves continue to stay separate over time, so long-term benefits seem to favor hormonally based approach. So obviously, we are dealing with a heterogeneous disease. We're seeing that patients will eventually die of prostate cancer. So can combinations further improve outcome by targeting both hormone-sensitive and insensitive clones when patients are metastatic? And the first analysis that was reported and will be published soon is from Piece 1, looking at ADT plus docetaxel as the standard of care treatment, adding abiraterone versus no abiraterone. And here you see that rPFS with the addition of abiraterone over docetaxel leads to improved rPFS and clearly improved overall survival. Is this for all patients? At least Piece 1 would suggest that the advantage seems to be more limited to the high volume patient rather than the low volume patient, where there was no significant difference in overall survival. It might be a question of time, that you need more time to see the advantage in the low volume patient. In terms of bone mineral density, this poster was presented just recently, showing that you should continue to follow bone mineral density in these patients when you start giving even just chemotherapy. ARASENS was presented here, and I'm showing you some of the slides that were presented by Matthew Smith, showing in a randomized controlled fashion that adding darolutamide to docetaxel and ADT significantly improves overall survival compared to patients who got ADT and docetaxel plus placebo. So it's over 32% reduction in the risk of death, clearly an advantage in these patients who were able to get to tolerate docetaxel and were judged in need of docetaxel. Interestingly, whether you had upfront de novo metastatic disease or recurrent metastatic disease after M0 at initial diagnosis, both groups seem to benefit to similar extents. So the thought that the biology is totally different if you are M0 and go to M1 disease might not be so true. Important endpoints: time to castration resistance was significantly delayed. On the flip side, that would mean that the time to castration resistance appearing earlier in the placebo arm had access to subsequent therapy. And even though they had access and did receive early subsequent therapy, the survival advantage was maintained. So just a word about localized or locally advanced disease. So we haven't done much in terms of improving over good local therapy plus ADT. And this study that was just recently published in Lancet by the STAMPEDE group again shows that in high-risk non-metastatic hormone-sensitive prostate cancer, adding 2 years of abiraterone to ADT plus radiation therapy in the high-risk non-metastatic patient significantly improves metastases-free survival and overall survival. This is something that I personally would not have expected. So this reveals that these patients that were put in the trial were truly high-risk patients with a high likelihood of dying with initial diagnosis of non-metastatic hormone-sensitive disease. So I'd like to conclude, and hopefully this was not too fast, but patients with high-risk non-metastatic CRPC and metastatic CSPC are both at high risk of rapid progression to mCRPC and early death. Treating all patients beyond ADT is the new standard of care for metastatic CSPC, and first-generation antiandrogens and complete androgen blockade are simply not enough for those patients. Effective agents are now available and should be used in all patients with CRPC and CSPC who are destined to suffer and die of prostate cancer. So this is where judgment comes in, life expectancy, all the rest. and the benefits of combining NHT and chemotherapy in metastatic hormone-sensitive prostate cancer is now, I believe, confirmed. Thank you very much.
Good. Thank you, Dr. Saad, an experienced presenter finishing within 1 second of his time. That was expert indeed. All right, so now we're going to move into the clinical investigator survey results. And again, this is meant to stimulate some conversation about how do we actually reach our decisions when we're thinking just beyond the guidelines and clinical trial criteria. So you see the questions on your iPads. This first question is talking about a 64-year-old man, radical prostatectomy followed by radiation therapy with M0 PSA only recurrence, receives LHRH therapy, then a further PSA progression. Setting aside regulatory and reimbursement issues, right? I mean, really just talking about how do we see the data. What would people do with a PSA doubling time of 10 months and a PSA of 3.4? And you can see the variety of answers that were given here. I'm going to ask my friend Dr. Agarwal, you're one of the few people who said you would continue with LHRH agonist alone. I guess, what's your rationale here?
It was 10 months. So if you look at the trials which led to approval of these novel hormonal therapies or next generation AR blockers, these trials had the inclusion criteria as PSA doubling time of 10 months or less. But if you really look at the patient population, in the published studies, the PSA doubling time was 6 months across the board, 6 months or 5 months. So in this case, I thought maybe I can wait until PSA doubling time goes up or goes down rather a little bit more so that this patient can mimic the clinical trial population and get the benefit while avoiding side effects for some time. So that is my rationale.
Fair enough. Dr. Beltran, how did you see this?
Well, I think that, we know that it seems that earlier is better, and this patient was likely, I appreciate Dr. Agarwal's points, but this patient would have met inclusion criteria, and these drugs are really effective in improving longer-term outcomes. And micrometastatic disease, using one of these agents, I think all three of these are acceptable. I think weighing side effect profiles, I tended to lean towards darolutamide, but I think that all of these were options, and I prefer to intervene earlier. I think these are metastatic patients, even though they're M0 on conventional imaging. And I think another discussion point is whether there is a role for PSMA PET in this situation as well. Thinking about oligo progression or whatnot, which there is very little data on. Dr.
Sartor?
Well, essentially, she made the points I was going to make. We're here to think a little bit beyond the guidelines, and PSMA PET could have utility here.
Yeah.
What happens if it's a single solitary med, and does that deserve to be radiated? What happens if it's only in the prostatic fossa? What about radiation? So, even though we look at the trials, and there's no doubt about it, we have 3 positive trials. Nevertheless, we still have lack of data with regard to PSMA PET that could have utility.
So you would think about going to oligometastatic, radiation for oligometastatic disease?
I would think about going to SPRT type approaches for oligometastatic disease. We really don't have a lot of good data in this CRPC setting, but you know what? I've done it, and sometimes it turns out really well.
And what about the narrative that some patients are receiving that would be potentially curative for them? What do you say to that?
I'm a little bit reluctant to endorse that sort of curative paradigm. I think it's too early. But I have seen some astoundingly long responsive in the hormone sensitive. But the best responses come in the best patients. So slow PSA doubling time, solitary, lymph node met. Those are the patients who do really, really well.
Yeah.
I think the question is whether you still add the AR pathway inhibitor in those situations. In my experience, I've done it in situations where patients are already on an AR pathway inhibitor, and you want to prolong time on that AR pathway inhibitor by doing oligomet therapy in CRPC.
I don't like to disagree with my colleagues here, but
that's why we're here.
Oh, but you should.
Yeah.
Well, this is a systemic disease. This patient has micrometastatic disease. He might be on the 10-month mark, but we did look at the sub-analysis of less than 6 months and 6 to 10, and both groups benefited to the same extent, whether it was rPFS or survival. And I think the data is showing that we're doing better when we treat earlier. So I would really, really encourage that the systemic therapy approach be the underlying theme. Now, the question of adding
Yes.
something to treat oligometastatic disease is a research question. I'm not convinced yet. This is not where I would spend money on PSMA testing, personally, because I don't think it changes outside of a clinical trial. But if there is something, I think it would be interesting. If you had a 20-month doubling time, definitely a PSMA. This is what we do in our center, because there is an opportunity of maybe delaying. But this guy is 65 years old. He will die of prostate cancer. And I think we will make a much bigger impact than waiting for him to progress even more.
I think you make an important point that we shouldn't be changing standard of care based on PSMA PET scans. And so I would also agree to add an AR pathway inhibitor, but potentially add therapy.
To me, it's about oligoprogression. And to me, there's something real about oligoprogression. I don't oppose Fred in the sense of systemic therapy, but what happens if they have an oligomet? What happens if they have one?
Yeah.
I mean, do you want to leave that one alone and start the
No.
darolutamide or apalutamide? And
No,
zolamide?
I think it would be a great tumor board question.
Yeah.
And we'd present those patients. Do we treat? Because it's not only one MET, it's where is that MET? And I've had oligomets, and the radiation therapist told me this guy has a 30% chance of having a severe complication in his intestine where it's located. So it really depends on the risk-benefit profile.
Absolutely.
But the level 1 evidence is the systemic therapy.
Add something.
Agreed.
We got 5 more questions to get through in the next 7 minutes. Okay? All right.
Message well taken.
But we are facing this situation in the clinic where patients are
Absolutely.
asking
Right.
what to do. Why shouldn't I get a PSMA PET scan? So we are seeing all this almost on a daily basis.
And to get the answer, they should watch Neil Love's broadcast where we have 5 experts debating the topic. Right? So most people would choose darolutamide as their agent in the M0 non-metastatic CRPC space. Someone want to at least kind of defend that answer? Why is Daro so dominant in this answer?
It's well tolerated.
It's well tolerated, right? I mean, I think we look at the toxicity data. There's a sense that it's better tolerated than the others, even though the patient choice data didn't suggest that there was, that study didn't suggest that there was a preference, right? But the toxicity data certainly looks better in terms of the asthenia, fatigue, CNS toxicity. All right. What about a 65-year-old man presenting with de novo, Gleason 8, metastatic prostate cancer, 3 asymptomatic bone metastases? Neeraj, I'll ask you, what would you do in this situation?
This is a low-volume metastatic castration-sensitive prostate cancer. So for me, this patient needs treatment with ADT and a NHT. I'm still I'm not leaning towards docetaxel chemotherapy. It's because the triplet therapy, I'm reserving the triplet therapy for those patients where I was planning, I would have started ADT plus docetaxel chemotherapy. So in this patient, I would not have started ADT plus docetaxel. And in that case, I would pick up one of the ADT and one of the NHTs. And my preferred NHT in this case is maybe apalutamide. I just picked up apalutamide, but it can be anything, enzalutamide or abiraterone. I think all are equally good choices.
So the high volume, low volume is kind of driving you to say, I won't use DOSI.
Yes.
Do you take into account patient age? Does it matter that he's de novo?
RSN trial and the PEACE-1 trial answered the question of efficacy of adding NHT to the backbone of ADT plus docetaxel. So the patients who are going to be starting ADT plus docetaxel, if you add NHT, do you see any improvement in survival outcomes? It did not answer the question whether adding docetaxel to the ADT plus NHT backbone would improve survival. So for low volume patients, I look at high volume versus low volume. In low volume, I usually do not think about docetaxel chemotherapy. I think about ADT plus NHT. So that's my approach here.
No, fair enough. Dr. Beltran, anything to add to that?
I agree with those comments. I do think it's important to distinguish de novo versus relapsed and high versus low volume disease in how we think about patients. But the evidence for an AR pathway inhibitor in this setting, regardless of what situation that is very strong. And we should be administering AR pathway inhibitors in those patients. the decision of whether to have docetaxel as well, I agree with Neeraj in that, I think based on how I'm wrapping my head around the data, I think at least for the time being, I'm going to reserve it for patients I would have done docetaxel anyway for, and typically my practice has been in the high volume, especially de novo disease. If there's any other sort of very aggressive presentation, I would try to lean towards the triplet. But for this patient, I would I tend to go to abiraterone because it's well tolerated. I would also, treat the primary tumor in this setting with radiation.
Yeah, absolutely. All right, we got a couple
And
more
also,
questions.
One second.
Yep.
There's also the question of whether you treat those bone metastases as well, which I would also consider.
No, fair enough.
And what about the primary?
And the
I think we
primary.
have
Yeah.
And the primary.
more the primary.
Yeah, I said the radiation primary.
and the primary.
radiation.
Exactly.
But I have a personal preference for an AR-targeted therapy. These patients usually are going to live quite a long time.
Yeah.
And I have issues, worrisome issues, with 5 years of prednisone, or 6 or 7 or 8. I had no issues with MCRPC, where the median was about a year or 18 months. But in these low-volume patients that might live way beyond 5 years, I have some concerns, and I agree. Abi is a great drug, but there's follow-up, hypokalemia, all the rest. There's more follow-up. So right now that we have access to the AR-targeted therapies, they become my preference.
All right, so the heart of this next question then is to talk about an elderly patient now, poorly controlled hypertension, otherwise similar. How does that affect your decision-making, Dr. Sartor?
Well, we have to worry about hypertension with abiraterone to a significant degree, but the apalutamide insulin also has some issues with hypertension as well. Now, I certainly understand the sort of movement away from abiraterone in this setting. Yeah. I think that you're going to be using a hormonal therapy. You're going to be using the APA-enza darolutamide. Now, the darolutamide is really a new choice, if you will, and we're still awaiting the FDA approval because the critical trials have yet to receive FDA approval. So it's probably going to be APA-enza. What I worry a little bit about, and I've seen this in my own experience, is that you have a tendency to get depressed and fatigued on these agents. And with apalutamide, you can have rash. You also have to watch for the hypothyroidism that can be present. So I would not use ADT alone. I would be using one of the other agents, but I would need to watch that patient very carefully because not only hypertension, but also fatigue. And these patients are very much at risk for falls. Yeah. And that's something else that can occur with the apalutamide and enzalutamide type drugs.
Yeah, yep, absolutely. All right. So going back to our 65-year-old patient, again, de novo, Gleason 8. Now here we go, moderately symptomatic, right? 6 bone metastases. Dr. Agarwal, I'm going to bring it back to you because this rounds out your thoughts, right? So the difference here is what?
The difference is high volume disease. So yes, as Misha said, de novo is definitely playing a role in my mind, but then I'm looking at the volume of disease and then symptomatic disease.
Yeah.
So here, I want to employ something for rapid cytoreduction, which docetaxel can do, and then add a NHT to that. So this is a patient where young man presenting with de novo disease, high volume disease, symptomatic disease. This is an ideal patient for triplet therapy, in my view.
And then Dr. Saad, maybe you'll round this out for us. So a similar patient again, but now we have visceral metastases, liver metastases at initial presentation. How are you thinking through potentially triplet therapy or doublet in this setting?
Well, this is, going in the same sense as Misha and Neeraj, this patient is at really, really high risk of early death and progression. These patients, I would also very, very much look at their PSA levels, which I expect would be lower than you would expect with the liver metastases. So definitely I would be going with the triplet therapy. But I wouldn't exclude it in lower risk patients. We might actually get some of the best results and maybe even cure a few patients with low volume disease with triplet therapy. So, I want to be provocative, but we might be concentrating on the worst patients. But none of our patients, or few of our patients, are cured with AR-targeted therapy and ADT in metastatic setting. And when they progress, they don't do so well on chemotherapy. And I think we have an opportunity early on. She's the expert in the clonal heterogeneity as patients progress. I think our biggest opportunity is up front. And I think we're going to end up with quadruple or quintuple therapy early and then stop after a couple of years. That would be my dream.
Yeah.
That we hit them hard, much like lymphoma, and then we leave them alone. They hate ADT. They hate our treatments for life, but it's become a dogma that we have to treat patients for life.
Yeah, yeah, absolutely. I agree with that dream, right? Let's try to cure this in the early going and stop. Absolutely. All right, we're going to move on to Module 2. Dr. Sartor.
Great. And I'm glad to be here, and I'm not going to be able to cover in 10 minutes what the topic actually has been assigned, and I've got a couple little kind of caveats along the way, so we'll move along. This is also out of date because I put it together 2 days ago, so we just have to forgive me for not being up to date today. But what I'll say is, and what has already been said, and I think it's been said by everyone here, is the new hormones are going earlier now, and there is more benefit. And whether or not it's the metastatic disease, whether or not it's the new STAMPEDE trial with abiraterone, whether or not you're dealing with overt metastatic disease, everybody wants to bring the new hormones up front because the benefit has been shown just time and time and time again. I think the docetaxel, to me, is a little more controversial because I'll simply say what Niraj said. We have clear data about the addition of the novel hormones to ADT, but does whether or not we have docetaxel adding to the ADT novel hormones, I think remains a little bit of an open question. So I'm not quite as engaged with the triplet therapy as some of my colleagues, just to say that. And then in the castrate-resistant setting, we have a whole bunch of other alternatives, which I don't really have the opportunity to cover in details. But what I will say is that we have a lot of life-prolonging trials, and these are the metastatic CRPC life-prolonging trials. And I've kind of divvied them up in different categories. We have the frontline trials, and that is the things like TAX-327, the IMPACT trial with simple cell T, Cougar-302, PREVAIL. You know, these are ones where chemotherapy was not utilized typically beforehand. And then we have the post-docetaxel, and that's where initially the AbbVie and Enza first came in with things like the AFFIRM and the 301 trial, and then the TROPIC trial, which is very important. That was the first trial to show you could have life-prolonging therapy beyond docetaxel. And then Alsemca, which is radium, was actually sort of a bifurcated analysis, both pre and post-docetaxel. Profound trial, which we'll be discussing a little bit more in just a few minutes. Very important trial, and here we look at sequential therapy. They all had to be post-AbbVie-Enza, and then they could be post-docetaxel as well. And then the third-line trials, if you will. They're not necessarily all third-line. I'm going to cover the vision in a little more detail. But the CARD trial is very, very important because it showed that the continual use of chemotherapy after the use of AbbVie-Enza is superior. And if we look at the next slide, what we see, we got 2 slides there. This is a CARD trial, and overall survival, which is actually not the primary endpoint, but it unequivocally demonstrated the use of cabazitaxel in that post-AbbVie-Enza, post-docetaxel state was beneficial. So take that home. That's an important lesson. Now, we now have some new trials, and this was presented, a little trouble with the slide advance here. Let's do it again.
Oliver, use this. Yours.
Oh, there we go. Clicking on the mouse instead. Thank you. Here we're going to be looking at the Prostate trial, which was presented today. And this trial was really looking at sort of a sequential use of enzalutamide and then continuing the enzalutamide or adding in docetaxel in those with disease progression. And what you'll find is the primary endpoint, to me, just really didn't show much of a difference. I think it was touted as a positive trial with a hazard ratio of 0.72, but I'm sorry, I look at this and I'm not impressed. That's an rPFS endpoint, and it's not enough to keep me impressed. And then we'll look at darolutamide maintenance, and this is from a trial, the SACC 08116, and you're looking at darolutamide maintenance in those with non-progressive disease after a taxane. And again, we have a primary endpoint of rPFS. It's a relatively small trial. We only have 90 patients randomized here. And again, the median PFS is really not enough different to keep me impressed. So I'm simply saying it's not going to change my practice. And yes, there's a little bit on the overall survival, but I'm not really sure that that's going to change my practice. Now, fractures. Fractures are important. It's already come up. Fractures are particularly important when you're using a compound like radium-223. This was presented by Silke back in the ASCO letter, the PEACE-3 trial, and these are individuals who are going to go enzalutamide plus radium. And what was unequivocally shown is that if you don't use the bone protective agents, that you're going to end up with a very high fracture rate. And if you do use the bone protective agents, that you're going to dramatically reduce and almost eliminate the fractures that are seen. Now, to me, sort of the interesting thing is not the Enza plus radium that you see in the left-hand column, but the Enza alone. And what you're seeing is, after 12 months, 15, 18 months, is fracture rates of 15.6, 21.9, 21.9. That's a pretty substantial fracture rate. And if you don't use the bone protective agents, you're likely to have 1 in 5 of your individuals have a fracture. Fred, I wanted to give a shout out to Fred because Fred did the original trial with the bone targeted agents and showed a difference. Fred, my God, was that 2002? I think, okay. He showed his age. He's getting a lot of gray hair. But no, I mean, that put Fred on the map and put bone targeted agents on the map. And I think we're just now seeing it again. Now we have other agents. We have the zoledronic acid. We also have the denosumab. So we have a few more agents today. But it's an important consideration. Now, I'm going to move on to PSMA. And I think everybody knows about PSMA to some extent. But what's interesting is that we can target the PSMA therapeutically. And there are a lot of different ways to do it. You can use lutetium, you can use actinium. PSMA 617 is currently sort of the famous one, but PSMA INT is now going to go forward in 2 phase 3 trials. And PSMA 11 is used for imaging, and that's been used in the predictive biomarker type setting. And I'm going to cover the lutetium 177 PSMA 67 data. It's important. I think it's going to be game changing. I anticipate that there will be an FDA approval, and that could actually come pretty quickly. So when we're looking at the VISION trial, and I'm not going to go over it, it's just simply saying that individuals who had already progressed post a novel hormone, typically Abienza, and then also progressed after at least 1 taxane, but could be 2 taxanes, that they would then be randomized to an alternative novel hormone or the PSMA lutetium. And there was a co-primary endpoint of rPFS and OS. The patients were biomarker selected, and it turns out that about 87% of the patients actually met the biomarker selection. So they had a PET scan with PSMA 11, gallium 68, typically had at least 1 metastatic lesion. Most, of course, had many more. And very importantly, no PSMA PET negative lesions of more than 1 centimeter in one of the visceral organs or more than 2.5 centimeters in a lymph node. So that's important. A lot of the patients were relatively heavily pretreated. If you look at the taxane regimens down at the bottom, everybody had at least 1 taxane regimen, but the truth is a substantial proportion, anywhere from 39 to 46.9% of the patients, depending on the arm, actually had 2 taxanes, most of which was cabazitaxel. Very heavily pretreated patients, and they really did not have a lot of alternatives. So the co-primary points, on the left-hand side, you can see overall survival has a ratio 0.62. rPFS, very strong, 0.4. And I don't really think that there's any question about the positivity of this trial, published in the New England Journal, submitted to the FDA, and hopefully something anticipated relatively soon. You can't see this in great detail, but you can look at it on your iPad perhaps. What I'll say is that fatigue can be a problem. Dry mouth can be a problem. Nausea can be a problem. Anemia can be a problem. So, it's not all roses and nice sort of things. So the dry mouth is not particularly problematic in most patients. It can be problematic in some. The fatigue can be an issue for some. And the nausea typically is very transient, so not so much there. Now, one of the things, I've been thinking about radiopharmaceuticals for a long time. I actually go way, way, way back to samarium-153 in the 1990s, started working in this area in 1993, and then the natural evolution was to go with the bone-targeted alpha, which was the radium. That worked, and then now the PSMA lutetium, and that worked. But I'm really looking forward to the opportunity to work with actinium more. This is a dramatic example. I'm not saying that everybody is like this, but there's some dramatic examples. And one of the things that I think that as we go forward, that these targeted alpha therapies are going to have a substantial role. But of course, we have to show the trials. We have to create the data that allows the guidelines to change. In summary, the selection, sequencing, and therapies depends on a number of factors. Prior therapies and genetics, it didn't have a really a lot of time to go into that, but we're going to cover it as a group going forward. Moving therapies up front can make a difference, and it really can. With the novel hormones, there's absolutely no doubt in my mind, but it has a lot of downstream effects. I do believe in precision medicine, absolutely, but I want to put limitations on our concepts related to tissue-based biomarkers. I'm not sure that they're perfect, and there are a lot of tissue analyses that are imperfect as we go forward. I like image-based biomarkers more. That's what we used in Vision, and I'll simply say we need to explore this paradigm more. I really enjoy the pace of progress today. It's remarkably fast, more than it's ever been before. Thank you.
All right.
0.0.
Another expert presentation, and you beat Dr. Saad by a second. That was beautiful.
That was intentional. I want you to know that.
You repeated the last sentence just to hit
I
the
did.
0 mark.
You're exactly right.
I saw it. Well
Sorry,
done.
Fred.
A master at work, everyone. All right, so we will go into the survey questions for this next segment. All right, so now we're talking about a gentleman who started with M0 disease, received DDT, and now has metastatic disease at castration resistance, asymptomatic bone metastases, number not specified, HRR testing negative. So again, for all these questions, we're going to set aside our regulatory and reimbursement issues. And the question is, what would we select? Dr. Beltran, maybe we'll start with you.
I typically go for an AR pathway inhibitor in this setting for a person that hasn't had one before, just because we know that they're effective and they're well tolerated, they're oral agents. I think, Sipuleucel T does have an approval in this setting for an asymptomatic, early CRPC patient, but again, now with the availability of AR pathway inhibitors, I tend to go for that first.
Okay, and Dr. Saad, you jumped right in with abiraterone and olaparib. The world has changed tonight.
Well, I had knowledge of some data that was just presented this afternoon. And so, this is a 65-year-old man, and we actually did a sub-analysis, and these younger men really had significant improvements in at least radiographic progression-free survival in unselected patients that did not have biomarker positive testing for HRR. We need to do better than what we're doing in first line. That's the bottom line. And what we found was an 11-month improvement in radiographic progression-free survival based on independent radiographic review in patients that got Abi plus olaparib compared to Abi alone. And amazingly, the Abi alone was a few hours difference in RPFS than the pivotal 302 data. So we are really looking at similar patient populations in terms of progression, and we're able to do it significantly better. Whether it's going to be approved, I just wanted to be provocative and say that I would at least consider this in a young patient who's first-line MCRPC.
Well, we're definitely going to talk some more about this data, right? It's definitely one of the big stories of today. Now, 3 people did say Sipuleucel T. None of the panelists gave that answer, but Oliver, do you want to at least address CYP-T in this setting?
Sure. We have level 1 evidence. We have a trial called the IMPACT trial in asymptomatic or minimally symptomatic CRPC. Phil Kantoff was the lead on that article, published 2010. And what you saw was an improvement in overall survival. Now, there are a lot of skeptics on Sipuleucel T because one of the things is you don't have responses. The PSA response rate, I think, was 1%, 2%. And there was no RPFS. So you're kind of left with that overall survival. What sort of bothers me a bit is that when we look over the totality of evidence, we have 1 positive trial. Yeah. And we've had a lot of changes since. So what about the Abienza? What about the use of the novel therapies that we use today, like olaparib? Would that still hold up? I don't know. I'm using less Sipuleucel T today. And I think, Fred's concept today was incredibly provocative. I told him right before the show started that I'm going to have to digest it a little bit, and I'm going to have to look over it in more detail. But it's very, very provocative.
Yeah.
I have digestive pills if you need, I have pills to help the digestion if you want. Accelerate the digestion.
Yeah, you've had more time to digest it than I have.
All right. All right, we'll move on to the next scenario here. So now, same patient, but now he has widespread symptomatic bone metastases. Again, genetic testing negative for HRR mutations. Perhaps we'll ask you, Dr. Agarwal, how would you approach this patient differently than the first, and what would you do here?
Well, this patient has widespread, moderately symptomatic bone metastasis. So I think this patient needs an active treatment. And in this case, I think all options, docetaxel is a good option, all novel hormonal therapies are good options. I would not go with radium-223 alone in this patient, just because of the widespread symptomatic bone metastasis presentation. But beyond that, I think abiraterone, enzalutamide, and docetaxel are good options for me. Regarding abiraterone plus olaparib, again, I will need time to digest the data. There are 2 trials. One trial was negative in biomarker negative patients. One trial was positive. I think we need a deal breaker trial down the line to settle this. So I have a lot of regard for Dr. Saad. I look up to him, but I need time to go over the data of abiraterone plus olaparib, especially in the context of the results of magnitude trial, where negative patients, we did not see benefit.
So we're swimming around the edges of this debate, and we're definitely going to dive in further here in a little while. So it's going to be an ongoing conversation without question for quite some time to come. All right. Anybody then, would you jump in with triplet therapy here? I mean, this is castration-resistant disease, so it's interesting that it's presented as a choice. But just the idea, do you jump from the hormone-sensitive data to say, look, same principle applies, we should do triplet therapy? Anybody take the bait? No? Okay. All right. Next question then. Now we have a 65-year-old gentleman, BRCA wild type, but with bone metastases, who gets ADT plus docetaxel, progresses a year later. So fairly quick as these things go. He goes on enzalutamide for 18 months and now has symptomatic bone progression with lung lesions. So what's the most likely appropriate treatment here? Dr. Saad?
I'm surprised that more people didn't vote for olaparib. I mean, this is the ideal patient for olaparib. He progressed on enzalutamide, had already gotten docetaxel in the hormone-sensitive setting. You know he is, he's biomarker wild type, sorry.
Yeah.
I thought he was mutated. No. This is, cabazitaxel will be my first choice for sure. I wouldn't repeat, and that's our experience of repeat docetaxel in somebody who's gotten in hormone-sensitive has been very similar to what the French have reported, very poor survivals and responses.
So if we change this stem to he responded for 4 years to ADT docetaxel, would you feel it?
No.
Okay, so no matter what, however long, once you've had your 6 cycles of dosi, you never get any more.
And we had patients getting dosi in neoadjuvant prostate trials years before.
Yeah.
And it's just disappointing at how they respond when you re-expose them. If you have an opportunity to use a completely different mechanism of action, these patients, I think, do better. And I would keep docetaxel. I wouldn't say I would never give it, but I'd like to exhaust other mechanisms of action before coming back to something you already got.
Yeah. Okay. Fair enough. All right. So if lutetium PSMA were available sometime soon, hopefully, Oliver, hopefully, right? Which of the following would you generally recommend first for a patient with PSMA positive mCRPC? And I guess, the question is, would anybody really say Cabazi before lutetium in this setting?
Yes.
Yes? Because?
Not for the average patient.
Okay. This
is, when we're really faced, and I'd like to hear what Oliver has to say, but, if he's got a heavily FDG positive disease, because I agree with Oliver, and we're doing a triple imaging study, and so much heterogeneity. So if it's predominant FDG positive, and there's controversy whether to do an FDG, but if I'm worried about liver mets and they turn out to be FDG positive, this is where I would consider Kabazi rather than lutetium. But for the average patient,
Yeah.
the
But
lutetium
what
would
if
be.
it's PSMA positive, FDG positive?
Yeah, but if it's FDG in the liver, I think, Oliver, the results were not striking in vision with extensive liver metastases, correct?
Well, I would simply stick with the vision criteria for now. And I think what was shown today by Michael Hoffman is that FTG is a prognostic marker. Everybody does worse if you've got
Right.
a lot of FTG. So I don't think you gain a lot.
Right.
If they're vision eligible, I'm not sure that you benefit from the Taxol. That being said, I think it's reasonable that you have two choices here. I think most people are responding. We got 16-3. I think most people are responding to the fact that it's better tolerated.
Yeah.
And if you look at the therapy trial that came out of Australia, it turned out it was a better tolerated option. And there they had a little better on the PSA. We did not compare the vision trial to cabazitaxel, but overall PSMA 617 is really quite well tolerated. I emphasize the dry mouth and a few other things because it's important. Some people think, it's like water. It's not. No. But nevertheless, it's a very well tolerated drug.
Yeah. I think it would be an exceptional patient where I wouldn't give lutetium. But there are exceptional patients, especially if it's a low PSA, FDG express. But I'm talking about, I think we need to think about, because most of these patients won't get multiple lines of therapy.
Well, so I think Dr. Saad's comments, right, are reflecting the complexity of the PSMA positive population. And we saw some data presented today talking about how you could have heterogeneous expression of PSMA amongst many metastases, some lesions being FDG positive, PSMA negative. Presumably, these are the lesions that are actually going towards that anaplastic state, the state that Dr. Beltran is the thought leader on researching, right? These very aggressive, devolved tumors. In that case, I think, to your point, Fred, I think a lot of us think cabazitaxel probably has to jump in at this point. Where do we go next with the imaging? Dr. Beltran, what are you doing at DFCI, right, to kind of sort out who are these small cell patients or that should go perhaps down a non-lutetium route?
Yeah, I think that it will be really important to look at the scans, the PSMA scans, and I think now that hopefully the scans will be approved with lutetium, and I think that's going to actually help us even in the small cell neuroendocrine route when we have patients that we might suspect that, because I think about this in patients that have low PSAs, visceral mets, and you would expect that maybe they would have lower PSMA expression. I typically do biopsies in that setting, but I think it'll be really important, we'll have the vision criteria, but these nuances of when do you do an FDG PET? Are there tiny liver lesions that you might need to consider that may have not met the threshold? What are the other clinical features of a patient that would make you lean towards doing maybe a platinum-based chemotherapy versus, even if FDG is prognostic, these small cells can respond to platinum. So these are aggressive variants, and where do genomics come in, tumor suppressor losses, and so there's a lot still to learn. But I think that the data right now does support for this patient to go, for most patients to go this route, but we have to be really thoughtful moving forward.
Yep. All right, one last question. So if lutetium PSMA were available, which of the following would you generally prefer for a patient with PSMA positive mCRPC and bone-only metastases? Dr. Agarwal, last word.
I'll go with lutetium.
Why not radium?
Great question. Radium, we don't see decline in the PSA. We don't see any progression-free survival benefit. In patients who get lutetium, based on the data we have, we see responses, we see PSA declines, we see radiographic progression-free survival benefit. And I think in this patient population, lutetium is going to replace radium.
Fair enough. All right. We'll close out this section. Module 3, Dr. Beltran.
Okay. The topic I was given to talk about was integration of PARP inhibitors, which we know is an evolving space now. But I just wanted to do a quick recap of where we are for biomarker selection for our monotherapies for PARP inhibitors, which will segue, I think, into what we think about the combination data. So it's an exciting time for prostate cancer. There's a lot of changes, but I think one of the biggest exciting things for me in the last few years has been the fact that now genomic sequencing is routine. We do have precision medicine treatments for our patients based on genomic biomarker selection and soon to be PSMA selection. And so we have olaparib and rucaparib. PARP inhibitors are approved for select patients. And then we have pembro, which I won't talk about, but is also a genomically driven patient population to identify patients most likely to respond to immunotherapy. And so the guidelines have now endorsed routine genomic testing for all of our patients. And I think this is creating some challenges, but also some opportunities to even look beyond these alterations as well. So there are two types of tests, of course. There's tumor somatic testing and germline testing, and both are recommended and are separate tests for all patients with advanced prostate cancer. And the timing of this we can talk about, but about 20% of advanced prostate cancers harbor homologous recombination gene deficiency, 8 to 10% of localized disease, and about half of those are in the germline. The most common alterations are BRCA2, ATM, CHEK2, PALB2, and BRCA1, but there are a number of other mutations involved in this homologous gene recombination pathway, and I think we're still learning about the function of those and when it comes to PARP inhibitors. There is data to show that paired samples from metastatic and primary tumor biopsies have high concordance when it comes to these alterations. So they tend to be early events in prostate cancer, and so we can go back to the primary tumor to look for specific aberrations linked to the PARP inhibitor approvals. When looking at the PROfound trial, the phase 3 trial that led to the approval of olaparib, they did screen over 4,000 patients to enroll 387 patients. And about 90% of patients on that study, they used archival primary tumors. And so this is reassuring that these were detectable in primary tumors. There are limitations. 31% of patients had test failures, meaning that quality of the tissue or the DNA wasn't sufficient to be able to detect these alterations. But nonetheless, the patients accrued, and there were 2 cohorts. So just to remind people on the study design, this was a randomized phase 3 trial of patients with metastatic CRPC who progressed on a novel hormonal therapy, and all patients had to have one of 15 gene aberrations involved in this homologous recombination pathway, and they were separated into cohort A or cohort B. Cohort A was BRCA1, BRCA2, and ATM, and cohort B had 12 other predefined DNA repair aberrations. And patients were randomized to receive olaparib or the other AR pathway inhibitor. And just going through the data very quickly, as I'm sure we've all seen this data, there was a significant improvement, and here's the rPFS data for cohort A with a hazard ratio of 0.34 of a significant improvement in these, again, BRCA1, BRCA2, or ATM patients treated with olaparib. You can see that in both cohorts as well, when you combine cohort A and cohort B, there was also an improvement, and the OS data was also positive in the overall population. And you can see separating by cohort A and cohort B there that this is primarily driven, I think, by the cohort A patients, but nonetheless, the drug was approved for 14 genes involved that were included in the entire cohort. Here are just some of the toxicities, the most common being anemia, nausea, fatigue, decreased appetite, and you can see the sort of the frequencies there. I'll just rush through this a little bit quickly, but you can see that on your slide deck as well. There were several genes that were not very well represented in the PROfound trial, and the most benefit has been seen for the BRCA2 patients, and you can see that there is a breakdown here on the bottom of gene-by-gene breakdown, and the ATM and the CHEK2, the CDK12, for instance, really not showing much of a benefit in the olaparib trial. So there's, I think, a great need to try to better understand, are there patients beyond BRCA that respond to PARP inhibitors as single agents? In the 2-PARP trial, which is a phase 2 trial of olaparib, looking a little bit more closely at biomarkers, looking at more nuanced details of that, the most exceptional responses are in patients that have homozygous BRCA2 mutations, so loss of both alleles. And in PALB2, similarly, biallelic loss was associated with benefit. In an ATM, and although many patients don't respond to olaparib, if there was loss of protein by IHC, this was associated with better outcome. And additional readouts like RAD51 or functional readouts of DNA repair damage might be needed to really identify those patients with CDK12, ATM, or some of these less common aberrations where we know a lot less. Triton-2 was the trial that led to the approval of rucaparib. This was an open-label phase 2 trial, similarly screened for a number of DNA repair aberrations, and the primary endpoint was radiographic or PSA, overall response rate. And here you can see the drug was approved just for BRCA1 and BRCA2, that you can see the radiographic and PSA responses here, and overall about 50% response, 43% radiographic response to 54% PSA response. And down on the bottom, you can see the BRCA2 was the most represented, but there were responses both in BRCA1 and BRCA2 and whether they were germline or somatic. Similarly, on gene-by-gene analysis in Triton-2, the other genes, really had a lot less responses. ATM, CDK12, CHEK2, no responses in the 11 patients with ATM germline mutations, although responses were seen in PALB2, FANK-A, BRIP1, and RAD51B. So again, we're still learning a lot about these other genes besides BRCA1 and 2, and there may be similarities between some of these other genes pathways as well. TALAPRO-1 tested another PARP inhibitor, talazoparib. This is a phase 2 trial where we now have data that also showed looking at a predetermined DNA repair gene list, very similar gene list. This is a post-AR pathway, post-taxane chemotherapy population. I think very similar results when it comes to response rates, radiographic and PSA response rates, particularly for the BRCA1, 2, and PALB2. Galahad was just recently reported. The difference here is that they require biallelic loss of these genes, and monoallelic was allowed only if it was germline. We could talk more about how we look for biallelic versus monoallelic, but again, I think that this is similarly showing fairly consistent responses for PARP inhibitors in the BRCA alteration arm. And this this is for niraparib, and niraparib did get FDA breakthrough designation for this population, post-taxane, post-AR pathway inhibitor. So PARP inhibitors are now standard of care for select patients with DNA repair aberrations, especially BRCA2, likely BRCA1, PALB2, potentially FANK-A, less pronounced for ATM, CDK12. Platinum is also an option for patients where PARP is not available, or even potentially post-PARP. And the biggest questions now are, should we be using PARP inhibitors earlier in the disease, and what is the benefit of combining with AR pathway inhibition, as there's biology for that, which I'm looking forward to discussing further. So I don't have much time, but just to think about tumor testing, I mentioned that primary tumors do have the advantage. They're not invasive. I still do think about metastatic biopsies sometimes, particularly when you want to look at acquired alterations or look at tumor phenotype. Liquid biopsies have a lot of advantages in that they're non-invasive, and they do have some limitations as well. And germline testing should not replace. Somatic testing should be done in parallel. There's data to show that ctDNA has high concordance when it comes to mutations in DNA, in BRCA, for instance, or any of these genes, but copy number aberrations are particularly challenging, including BRCA2 deletions, which I mentioned sometimes have the most exceptional responses to olaparib or other PARP inhibitors. And the one major limitation of ctDNA is that you can't detect clonal hematopoiesis. And so clonal hematopoiesis are mutations found in some of the ctDNA assays where they're derived from mutations derived from normal white blood cells, not from the tumor, and they can involve things like ATM, BRCA2, and CHEK2, which are linked to the drug approvals, yet these are not coming from the tumor, they're coming from white blood cells. This happens in people as they age and occurs in about 10 to 20% of individuals. And so if this is found, particularly low allelic frequency in ctDNA, you can distinguish this using paired white blood cells or looking at tumor tissue to confirm. And I only have 11 seconds, but I just want to quickly tell you about this patient that I have who was post multiple lines of therapy, Abi, Josi, lutetium, actinium. He had a ctDNA that showed a BRCA mutation. He had biallelic loss on his primary tumor. We started olaparib, dose reduced due to low counts. His PSA actually went up from 650 to 783 before it went down to 110. So this can happen with any systemic therapy with patients in CRPC, but he did have a great improvement. But unfortunately, he developed a new cord compression, and we repeated his ctDNA, and he now has 16 new BRCA2 mutations. And so these are reversion mutations, and reversion mutations essentially convert this mutated BRCA mutation into a wild-type frame, and you can get many, many of these mutations detectable on ctDNA. And it's a resistance mechanism, and I think it's important to recognize once we start thinking about sequencing platinum or other potential agents that may affect this pathway for this population. So that's all I have, and look forward to the discussion.
Very good. Thank you so much. All right, we will get into our survey results. So in general, what's the optimal approach to mutation testing for possible use of a PARP inhibitor for a patient with MCRPC? I guess, Dr. Beltran, this is your module. Do you want to take a first shot here?
Yeah, so I typically test fairly early in a patient's disease course, thinking a patient is going to eventually we're going to need the testing. So I often go to primary tumors. I know everyone does it very differently. I think that the right answer would be to do a metastatic biopsy, but that's really not feasible all the time, especially for patients with bone-only metastasis. And so when looking specifically for PARP inhibitor eligibility, I often go to the primary tumor, but I also do ctDNA testing at the time of progression. So especially if the primary tumor is negative, I would, but even so, I like to know what else is present. And so I don't know if that's the right textbook answer, but that's what I do. And I actually also do sequential testing of ctDNA because I have found acquisition not only of homologous recombination, but even mismatch repair and hypermutation with patients that have benefited from treatment. So that's my approach to testing. I test often and frequently. Not frequently, but more than once.
Yeah. Oliver?
Early and often.
Early and often.
Yeah, so, I mean, initially I was kind of holding off on the actual prostate biopsies and primary tissues because I was thinking, gosh, the evolution in the assays are moving so quickly. If I wait, then I'll probably have better technology to look at that tissue. But right now, the technology is so good, I just go ahead and send off the primary, and then I can look at the ctDNA, and of course, I always get germline.
Yeah.
And I mean, germline has such implication for the families that you can't ever miss a germline. So I'm very compulsive about that. But I agree with Misha, early and often.
Yeah, like voting in Chicago.
Yep, exactly.
Too soon, sorry, right? All right. This point about germline is tremendously important, right? I mean, this is a recommendation now, and yet I think, if we were to do the same kind of retrospective analyses that we've done for combination therapy in the first line setting, I think we'd find that there's a big gap, right? So what is the messaging? Why is there a gap in terms of testing for germline amongst practitioners? And how are we going to overcome that? Neeraj, what are you seeing? I mean, Huntsman is such a leader in germline testing.
So I think the biggest roadblock was the lack of availability or easy availability of genetic counseling. Yeah. That was, I think, the single most common problem faced by community-based clinicians where patients are seen, where most of the patients are seen. I think pandemic had a lot of bad things, but some good things happened. And one of them is the virtual availability of remote genetic counseling. So now it is so easy to get genetic counseling for patients who are undergoing germline testing. So now we don't have any reason not to do that. And there is another reason. I obviously cannot disclose this for the sake of confidentiality. It is a potentially medical legal issue now. If we see these homologous recombination repair mutations inside the tumor, and if we don't do germline sequencing, And it turns out one of the family members of the patient of prostate cancer, like say daughter or son, if they develop cancers down the line, and they are found to have germline mutation, it is a medical legal issue now. So just wanted to make that comment.
Yeah, well, quite apart from medical legal, none of us would feel good, would we, right?
Yeah.
If our patient comes in and says, you know, my 35-year-old daughter has ovarian cancer and she's BRCA positive, and why didn't you test me, doctor?
Yeah.
Right? And it's inevitable, right? It's inevitable. It's going to happen statistically. So a couple of take-home messages today, everyone. Please do get germline testing on all your high-risk, very high-risk metastatic prostate cancer patients. That is guideline-directed care, right? So if you're not doing it rigorously, please do. Also, please use anti-resorptive therapy, bone protective agents rigorously. Again, I'm sure if you did a quality improvement check on your population, you'd find that there's a big gap. I mean, we know that from the data. So, you know, just applying available tools leads to better outcomes, and these are easy wins applying in clinic tomorrow.
If I may, just want to add regarding the somatic testing. So I had the privilege of being involved with the PROFOUND trial, and Oliver, we were together doing PROFOUND trial, and we saw that out of 4,000 patients tested or screened initially for these DNA repair mutations, 1/3 did not have adequate tissue of good quality or quantity when they were being tested for the trial. So out of 4,400 plus patients, 1,700 patients did not even have tissue of quality or quantity to allow them to even screen for the trial. So my practice has since changed. We do somatic tumor testing on the first day we see the patient. Like when we order CT scan, a bone scan, I don't wait for technology to improve like Dr. Sartor said. I just order, because when patient develops castrate-resistant prostate cancer, it could be 5 years from now. And by the time the original prostate tissue will be gone, and 80% patients with prostate cancer have bone metastasis, and sometimes we do not get tissue to test for them. So I think it's very important to test early and early during the course of disease. Yeah.
So I totally agree. I mean, whenever there's an opportunity early and doing it at the time of diagnosis is best. But I just want to come back to the often, because my understanding is that when you have it up front, and you don't develop it very much after. And this is discussions we've had of the necessity with Joaquin Mateo and others. So I don't know, that was surprising from your
Yeah,
comments.
you know, I think it's true that most of the time they're early, they're clonal, they're there, they're present. But, you know, I have seen acquisition, and it's not that common. And, you know, and also we're thinking about other trials and other, you know, there's other reasons to check
That's an interesting.
for acquisition of alterations.
All right, we'll get on to a few more questions here. All right, 65-year-old man, germline BRCA2 mutation on ADT plus Enza for HSPC metastatic to bone, now has high volume symptomatic bone metastases. So what systemic therapy would you recommend at this point? Really, is there anybody that would say you would do something other than a PARP inhibitor?
You know, I can be provocative just for a second.
Conversation, yeah.
And you know, but particularly before the PARP inhibitors were available, we really had good data with platinum. And this has been published in several series and subsequently published in larger series. Not always is olaparib affordable, and particularly if you're dealing outside the US, you can potentially substitute platinum. I'm not saying it's the ideal substitution, but platinum is active in these BRCA2 mutant patients, and that's a fact. And you need to keep that in mind if you don't have access to the PARP inhibitors.
I agree. I think it's also important to keep in mind that, you know, we've looked also at patients treated with docetaxel. They respond just like non-BRCA. So you shouldn't deprive people of, you know, I think in this patient I would give a PARP inhibitor, but you know, patients should still respond to standard of treatments as well.
Yeah, so we don't actually have the trial yet, right, with comparison of PARP to docetaxel. We'll probably get that out of Triton-3. That's finished accrual, and docetaxel is in the control arm. But that'll be the first data set where we'll have a comparison. Doci is not at all inappropriate in this patient, right? Certainly an option.
No, especially that this patient is symptomatic, and if it takes time to get access to olaparib and for it to kick in, it's not always overnight that the effect is there. So when symptomatic, there's a range of what symptoms are. So severely symptomatic on opiates, there's an urgency to intervene, and I don't think it would be ludicrous to start with chemotherapy, but usually you should be able to detect this before they get into this problem. On ENSA, PSA is rising, imaging is changing.
Yeah.
It's unfortunate if we waited for them to be very symptomatic before starting to think of the next line of therapy.
Yeah, fair. All right. Now we have a gentleman, again, germline BRCA2 on ADT ENSA in the first-line HSPC setting, now with low-volume asymptomatic bone metastases. Dr. Agarwal, let's ask you, what do you do here?
Olaparib, germline BRCA mutation and relatively asymptomatic patient.
Yeah. Abiraterone plus olaparib, we'll talk about that in the next segment. It's coming up.
No, there's no data. This is in the MCRPC. This is post-ENSA.
Post-ENSA, right.
Yes,
that data doesn't exist. That's right. Yeah. All right. All right, so 65-year-old man now with a germline PALB2 mutation, minimally symptomatic prostate cancer of the bone, now in the CRPC setting. Dr. Beltran, what about PALB2? What's the message here?
We have less data for PALB2, but I tend to think of PALB2 more in the lines of BRCA, and that's been the case in ovarian cancer and breast cancer as well. And so I think from a functional and from a therapeutic point of view, I would lean towards PARP inhibitor, even though we don't have as much data as we do for BRCA.
Yeah, I mean, there's a long tail of the curve, of course, in these less common HRR mutations. PALB2, though, consistently is falling out as one where we're seeing responses, right? In small numbers, but nevertheless consistently. In the various studies. So here again, docetaxel is not a bad option, right? But the message around PALB2 is important. Now here's potential more controversy. So maybe we can get into it a little more. Now, same patient, germline ATM mutation. What do people recommend in this setting? Docetaxel has taken over as the most popular answer over a PARP inhibitor here. Who wants to take this? Oliver?
Sure.
Why? Yeah.
Yeah, so if you look carefully at ATM, it's very controversial. So first of all, if you look at PSA responses, it's pretty low. You look at objective radiographic responses, it's pretty low. If you go to the profound data, there was actually a discrepancy between the pre and the post-docetaxel. And nevertheless, those are small subsets, and I don't think we have a lot of trust. If you look at the very nice data that has been presented from Jon de Bono and colleagues, you see that there are occasional responses for ATM with the PARP inhibitors, but it's clearly not BRCA2, and I don't even think it's PALB2. So I chose docetaxel because I have more confidence. So I look at the germline mutations as an individual. I try not to group them together. I know the cohort A of Profound did put the ATM, BRCA1, BRCA2 together. I split them apart, but that's just me. I'd like to hear from what the others do.
I think these are patients that might respond to ATR inhibitors, and so thinking about trials related to ATR, I think it's important to find these patients. ATM germline may have family implications as well. I agree with Oliver. I wish there was stronger data. I would say for other mutations like BRIP1, where we really know even less, in a situation when you're running out of options, I have tried PARP inhibitors. They're approved, and hoping that they may be the patient that responds, because there are some patients that do. But again, an ATM patient, I think the data just is consistently through all of these studies not showing impressive responses with PARP inhibition.
Yeah, I agree. We haven't taken any audience response questions, but I will take this, ask this question very quickly. Dr. Beltran, the person's giving a case of having treated based upon a VUS, seen a response with a PARP inhibitor, but what is your narrative then around a VUS? What should we be telling the audience? Variants of uncertain significance, what's your advice?
I talk to my pathologists a lot when these happen, just to make sure, that, sometimes we have VUSs, we don't have the functional data yet, but they're pretty good at classifying these as VUSs, and I do not usually act on a VUS because that they are of uncertain significance, and there are commonly mutations involving some of these genes that are just not functional. So I would have a very, I haven't really done that before.
Yeah, fair enough. All right, we'll move on to the next segment. I will try to finish on the mark. We'll see how this goes. So I was asked to speak about the emerging data with combinations with PARP inhibitors in prostate cancer. Obviously, some of it has emerged as of this afternoon, so we'll get into some of that conversation as well. And it's really this movement towards combination therapies. These are my disclosures. Okay, so in terms of why do we do combinations, in the ideal setting, we're looking for synergy. We're looking for mechanisms where two drugs will make each other more effective than individually or sequentially. But of course, it's a fundamental question to ask is there a reason to do things together rather than sequentially? And as we think about this, we think about overlapping toxicities. Is it possible, for example, that drugs would undermine each other by increasing toxicity beyond what's going to be tolerable for the patient and causing a loss of the therapeutic window? But when we're hypothesizing around combinations, we always start with our preclinical data wherever possible. And so when we talk about PARP inhibitors and second-generation androgen pathway inhibitors, ANZA, ABI, APA, what we're thinking about the preclinical data saying that PARP inhibition and AR pathway inhibition, being distinct approaches with non-overlapping toxicity, we nevertheless know that AR signaling regulates DNA repair in prostate cancer cells, right, at least in cell line data, and that there's potential for synergy then by manipulating AR signaling to then increase the susceptibility to DNA response inhibition with PARP inhibitors. So the early data that led to some of the data we saw today, of course, there's a Clark study. There's a phase 2 looking at patients who had prior chemotherapy, gave them olaparib and abiraterone. In this case, no genetic selection. I mean, this really was the basis of Dr. Saad's study that we heard from earlier today. And this was 171 patients. And the primary takeaway there was that, in fact, there was an improvement in radiographic progression-free survival in that study, 13.8 months versus 8.2. Overall survival, again, this is a phase 2 study. It wasn't powered for it, but nevertheless, there was a hint of benefit there. So this was, this is what gave enthusiasm to the PROPEL study that we'll talk certainly more about. And then we also saw the data of niraparib plus abiraterone or niraparib plus apalutamide. This was Dr. Saad's phase 1b study. Again, this is metastatic CRPC patients who had first line of prior taxane-based chemotherapy and at least one prior androgen pathway inhibitor. Again, no genetic selection. Important here was the fact that niraparib plus abiraterone was found to be well tolerated with no significant safety signals, but the other combination of niraparib plus apalutamide was in fact found to be toxic. There was really synergistic adverse events there, and that's why you haven't seen that move forward as robustly, even though I think at the time there was some hope that that would be the combination to move forward. So nevertheless, we had a recommended phase 2 dose that came out of that study and has moved forward in subsequent studies. So, I think this will take up the bulk of the talk today, and probably we'll try to make some time in the discussion in the next segment here. But we had the PROPEL data, so we saw this presented this afternoon. Again, this was abiraterone with olaparib or placebo in a genetically unselected population, despite everything we've been talking about. Now, there's a mistake on this slide because I've since spoken with Dr. Saab and kind of corrected a misunderstanding that came out of the discussion panel today. Serum was collected for cell-free DNA on all patients, so was tissue. Tissue testing was done on 70% of patients. So that, you're talking about 30% of patients where it could not be accomplished, which is consistent with other studies, right? Old tissue, especially, and this gets to a point we were hearing earlier about testing the primary, the older the tissue gets, the more likely you are to have a failure of testing. But all the patients did have both serum and tissue genetic testing done. Tissue was submitted for NGS. Remember, in this study, the NGS was done retrospectively. It wasn't done at the time of enrollment. It didn't impact enrollment. The primary, is that right, Dr. Saad?
Exactly.
Anything to correct?
Perfect.
Okay, fair enough. All right. The primary outcome here was radiographic PFS. We saw this data, and I've got it listed there. You can see the differences, though, in the hazard ratio for the HRR mutated and non-HRR mutated population. Now, the comment was made during the presentation that the test for interaction here was negative. But remember, tests for interactions are statistically very weak tests, highly dependent upon the sample size. This is a considerable and clinically significant difference. It would be a mistake to say that the test for interaction suggests that the HRR status does not matter. It certainly does, but nevertheless, the overall study is positive. Now, the magnitude study, remember, a significant difference here, and I'll get into the study designs of the two a little bit, but this data set is looking specifically at HRR mutated patients. In the magnitude study, the futility test for the HRR normal patients was negative, so those patients are removed from analysis. And here you see, again, it's radiographic progression-free survival, a positive outcome, OS not yet mature, but when we put these data side by side, I mean, there's going to be some nuances here, and it's going to get into maybe the conversations we heard earlier today. So on top, you'll see the two study designs. I put that there for your own reference. I'm not going to talk about it, but it's in your slide deck. But side by side below are some of the eligibility criteria, and there are some differences. In PROPEL, in both studies, no prior abiraterone was allowed. In magnitude, they could have been on abiraterone for 4 months heading into this study, so there can be a little bit of lead time bias when you think about the numbers and an impact on the overall outcome. On the magnitude study, opening a little later, prior NHT, second generation, was allowed going into the study as opposed to PROPEL where it wasn't, and we didn't get a breakdown of exactly what those numbers looked like. In PROPEL, they had to have been on essentially ADT monotherapy for the last 12 months before enrollment. They could have had an NHT in, say, an adjuvant or neoadjuvant setting if they had been on a study or something. I would point out the fact that the radiographic PFS on the control arm was very different between these two studies. So, we had some conversation about trying to think about why is the PFS so different between these two studies. But again, the control arm was the same. The fact that these were considerably different, I think, really speaks to the fact that the patients going on these two studies were not identical. And I think it would be very dangerous in that kind of setting to try to make any comparison between the two PARP inhibitors and suggest that there's some conclusions that can be drawn. I would say based on the control arms, you really can't do that at all. These are very different populations, and I'm not sure why, but I think the data certainly tells us that they are. It may just be the prior NHT use. If you look at on the PROPEL study, the 28% or so of HRR positive, that's right in line with what one would expect in an unselected population. So I don't think there was any enrichment here. This really reflects the general population of metastatic CRPC. All right, we're going to come back to all that. I have to finish up the last couple of topics that they really wanted us to address here. What next in the combination of PARP inhibitors and secondary hormonal androgen pathway inhibitors? We have multiple phase 3 studies coming online with 4 different PARP inhibitors. 3 of them listed here. You have Amplitude looking at niraparib and abiraterone and MHSPC, and also Talipro looking at talazoparib, enzalutamide again in MHSPC, both studies accruing. You have in the MCRPC setting, talazoparib plus enzalutamide versus placebo enzalutamide, and CASPER, which is rucaparib enzalutamide versus placebo enzalutamide. These are very large studies, as you can see from the numbers, so there is going to be a wealth of data coming out about PARP inhibitor and NHT combinations. These are all selected studies, genetically selected studies, so none are really going to reproduce PROPEL. But then there's also data about PARP inhibitors with checkpoint inhibitors, and some of this is quite exciting, or at least compelling, and you're going to see a lot of data about this in the coming years. The rationale for the combination is because in preclinical models of various solid tumors, PARP inhibitors are found to have pro-immunogenic effects, including activating cytotoxic T cells, upregulating immune checkpoint expression, and sensitizing tumor cells to natural killer cell killing, and increasing pro-inflammatory signaling. And I've listed some references there if you'd like to look at it, but there is a rationale to say that PARP inhibition actually creates a more pro-immunogenic environment. And then in breast cancer models, we see that PARP inhibitors are upregulating PD-L1 expression. So again, if you want to use a checkpoint inhibitor at all, perhaps it's best to use the PARP inhibitor in advance. Now, I've listed various studies there with some of the early preliminary data, but you can see overall response rates, in one case going above 50%. So again, at least exciting for future consideration. So in summary, PARP inhibitors can be safely combined with many other agents. On the right there, I include a graphic that a couple of our fellows and one of our early faculty derived, looking at the various targets that we've been talking about. And then, I think we're going to get into this. Propel and Magnitude, I would say these are very different studies. I don't think there's space for meaningful cross-study comparisons here. It's just not possible, especially when you look at those control arms being so vastly different. The overall survival data will certainly be critical. There's no question. These studies have not established that concurrent is better than sequential, but the PFS data is very impressive. There's no question about it. But we do have to wonder about prolonged treatment with a myelosuppressive drug impacting later lines of therapy. And this is a primary concern for me if you consider the possibility that some significant proportion of patients are deriving no benefit from the PARP inhibitor and will have no idea because the AbbVie is so effective. We'll stop there and move on to the questions, but a review of the more detailed data in the respective publications I think is really going to be crucial. All right. Fred, you want to say anything before we jump in?
No, maybe just to comment, unless you were going to discuss about the control arms being different.
Yeah.
The control arm that you showed for Propel was the all-comer population.
Yeah.
But for Magnitude, it's the biomarker positive. So
Yep.
already we know they don't do as well with AbbVie.
different
But even in our biomarker positive patients, the control arm looked like it was doing a little bit better.
Yep.
So why could that be? They had a lot of BRCA2 patients in their biomarker positive, and they probably do the worst in terms of responding to AbbVie. So there might be at least some explanation why the control arms are different, but I agree. I don't think we should make efforts of cross-trial comparisons, but take what we can learn to move forward with both trials.
Yeah.
And I have a comment on the TALA-PRO-2 trial. There is a 750 patient portion of 1,035 patients, which is going to mimic the Propel Propel trial.
Absolutely.
So those are unselected patients. Those are not negative patients, but unselected patients.
Yeah.
So let's hope that it replicates Propel trial. Yeah.
It's a clever statistical trick that they've incorporated into the study, but you're right, it'll be interesting data. Yeah. All right, very good. So we'll get into the questions here. How much benefit do you anticipate will be seen in the Propel and Magnitude studies? We don't have to anticipate, right? In patients with BRCA wild-type disease. So this was people's expectation before seeing the data. In the BRCA wild-type, most people were expecting minimal. Fred, I think you'd say it's more than minimal. A response to this?
No, I would say it's moderate. I don't think we've cured anybody yet, but I think we're looking at the hazard ratios of 0.76 in the wild-type population, especially that they're on the right side of the significant line that we would hope to see in a subgroup.
Yeah. Oliver?
One thing that worries me a little bit, and Fred, forgive me if I try to point out that hazard ratio of RPFS is not very good. You're going to think that the overall survival is always going to be shifted much closer to 1. Mm-hmm. I mean, if you look at Vision, you go from 0.4 to 0.6. If you look at other trials, you go from 0.5 to 0.7, et cetera. So the bottom line is, I'm not sure we're going to have a survival benefit there. And then there'll be a debate, I think, about, okay, so what do you gain if you don't prolong survival? To me, in a conservative way, if you will, and I'd like to hear your response because I'm very interested in how you think, but living longer, living better are the two things we really strive to do. And living about the same, which is what the health-related quality of life is good. I mean, there wasn't a detriment, but there was an addition. And if we don't add to survival and the RPFS turns out to be 0.76, is that a practice changer? So I'm not trying to be overly skeptical, but I want to voice my opinion.
I think we need to wait for the overall survival, and the 0.76 is with investigator initiated. You know,
Okay.
it's not the 11 months that we got with in blinded review, which was actually even better. I mean, we're actually improving over a standard of care.
Yeah.
And I would just like to maybe make a pitch that if we want to move forward in this disease, we're just going to have to stop accepting that only placebo-controlled trials are going to lead us to new drugs, because every drug we use today has had an inactive or a placebo control. Every single MCRPC study. So, you know, the bar is really high if we're going to be wanting overall survival to change or to bring new therapies. You know, and these are centers of excellence that actually do sequential therapy. The real world is less than half the patients actually go to second line. So we have to do better than we are doing right now in the first line. I'm not saying this is the answer, but we absolutely need, and you're leading a lot of trials. It's a primary endpoint of RPFS in every trial I'm involved in MCRPC.
Yeah. No, good point, Fred.
Very good. All right, we'll move on to the next question. All right, so we have a 65-year-old man, germline BRCA2 mutation, who's receiving ADT and docetaxel, ultimately moves on to develop high-volume symptomatic bone disease metastases a year later. Regulatory and reimbursement issues aside, what systemic therapy would you most likely recommend? Dr. Beltran, what do you do here?
You know, I'm still trying to wrap my head around everything with the combination. I think that the data from Propel and Magnitude do suggest that a combination of AR pathway inhibitor and a PARP inhibitor in a BRCA setting would be of benefit. And this is a biomarker selected population, obviously, which is different, you know, kind of extrapolating from the studies. And so this patient hasn't had abiraterone. So, you know, I think before seeing these data, I think abiraterone or a PARP inhibitor would be things that I would be thinking about, or enzalutamide, you know, an AR pathway inhibitor, but now I think, you know, as I'm still, you know, absorbing the data, that I would consider doing abiraterone plus olaparib based on what I've seen.
Of course, I at least don't live in the world of regulatory and reimbursement issues aside, right? And we certainly think about what it's like for a patient to pay for 2 oral agents out of pocket with the copays in the United States, at least with our system and how it works. So how do I explain to my patient, right, why I really think they should do both drugs together now and why they shouldn't just do one and then the other? Anybody?
You know, I mean, for me, when you look at that BRCA2 and whether or not you're looking at the Magnitude where you clearly had a good effect and you're looking at Propel where it's clearly a good effect, I mean, I'm pretty convinced in the HR positive mutation that the combination potentially does have some synergy. I do worry about sequential treatments in a way because sometimes people just fall off the curve.
Don't get there.
Yeah. I mean, you know, I mean, banking on your future treatments is perhaps a good strategy, you know, when you're 6 or 7 years old and you've got a long way to go. But you know, these metastatic Super C patients, I mean, sometimes they just collapse and go bad. And then you don't have that follow-up therapy. So I would be pretty comfortable with combination here.
Yeah.
I'll have one more reason for using doublet here with abiraterone plus olaparib. Consistently, real-world studies have shown there's a 50% attrition from first line to second line. So anytime we let patients progress, we lose half of the patients in the real world. So this combination approval, pending approval, will allow us to treat our patients with both drugs and not lose 50% of them who will not be able to get olaparib later.
Absolutely, I agree. I mean, this patient is a profound patient in the next few weeks. Put this patient on who's already gotten chemotherapy, who's already symptomatic, and you follow PSA closely. He's either not going to respond or start to progress within less than 6 months. And then you get into the profound situation. And I think we have an opportunity now to maximizing 2 therapies that might actually synergize each other. So, you know, reimbursement aside, I think this is the ideal patient. To hit them hard early, even if they had docetaxel and were not mutated, but docetaxel mutated, symptomatic, there's an urgency to get something into this patient that's going to make a difference.
All right, very good.
The other choice would be cabazitaxel. You know, I mean, this is a bad patient. This is a
Yeah.
bad patient.
Yeah. Yeah. All right. So now a 65-year-old man, germline BRCA2, receiving ADT and docetaxel in the first-line setting, develops low-volume asymptomatic bone metastases a year later. In this setting, what would you recommend? Dr. Agarwal, what would you do here?
So this is a patient who received, did he receive chemotherapy in CRPC setting?
No.
No. So this is, again, germline BRCA2 patient progressing to new CRPC. Again, I would go with abiraterone plus olaparib. Yeah.
Are we convincing everyone? Right? Everyone ready to do this?
This is BRCA2, germline positive.
Yeah.
This patient needs olaparib.
Yeah.
So earlier versus later, that's the question we are asking.
And
Yeah.
if I may point out, for those who may wonder,
Yeah.
this questionnaire was filled out before the Propel data was presented. So
That's right.
I think it could have been different had it come today instead of yesterday.
But I think until reimbursement, this is probably going to be the scenario where people are going to have to fight to do a combination, but they're going to go sequential. Hopefully, they'll follow patients very closely so they don't miss, as Niraj rightly says, the opportunity to get in the next line of therapy.
And I'll make a small pedantic point, but rucaparib and olaparib aren't approved in this setting, right? I mean, they're both approved post one androgen pathway inhibitor. The patient hasn't had one. So we could say you want to give it. I think we all want to treat BRCA2 with a BRCA2 directed agent, whether platinum or PARP, but technically speaking, in the US at least, you may not be allowed to do this. All right. Which of the following do you predict regarding the global tolerability toxicities of a PARP inhibitor combined with a secondary hormonal agent versus what might be expected from either of these approaches alone? So let's talk about the toxicity data. Misha, Dr. Beltran, I'll give this to you. What's your narrative going to be with patients?
Well, I think that the data we saw today was that the increase was not significant. And there are toxicities, though, with PARP inhibitors, and there's toxicities with AR pathway inhibitors, and they're different, and you have to manage them. And I think particularly the anemia with PARP inhibitors, and especially if patients are on these for a very long time. So the monitoring will be different, but I think that you have to weigh that with the potential benefit seen. I don't know if, Fred, you have anything to add from what you've seen in Propel?
At least what we saw in patients on the trial, and I don't know if others were on the trial, I had a hard time knowing which ones were actually on the olaparib. It was surprising. Seeing anemia creep in metastatic CRPC patients on long-term ADT for 5 years is not something that makes me lose sleep at night. There were a few patients that needed transfusions, yes, but they surprisingly well tolerated. I can't really speak for the magnitude, but for the Propel, surprisingly well tolerated, but it's well taken. I mean, if they're going to live 5 years on a PARP inhibitor, I don't know the long-term toxicity yet.
Let's see. Well, Fred, I'm just curious, what percentage of the patients had an olaparib dose reduction? Do you know?
It was about 15%.
15%. That's it.
20%.
Yeah, that's
it was
pretty good.
15% versus 8% that left the placebo. So it was in that. And for abiraterone, it was 8 and 8 in both arms. So it didn't look like olaparib made us stop the abiraterone, but the olaparib was dose reduced or discontinued slightly more than in the abiraterone.
Okay.
But we started at full dose. Just remember that we didn't dose even though we gave the combination. It's full dose olaparib, full dose abiraterone.
But that's what you would expect with olaparib monotherapy. So it didn't really have to be dose reduced more because it was being combined with abiraterone. That's a bigger question here.
Yeah, and my feeling was it was better tolerated than Profound. But these are earlier patients, right? Their bone marrow is in better condition.
Yeah.
They didn't get chemotherapy. They didn't get an NHT for years. Anything we give in the first line, patients tolerate better.
Yeah.
All right, we do have a little bit of time left, so we'll get some of the audience questions here. To the panel then, any thoughts on why the Magnitude trial didn't show benefit in this HRR negative subgroup, right? And how do you interpret that in the context of Propel, looking at all comers? What do we say about the negative portion of Magnitude? Still digesting.
I mean, I was a little bit taken aback by the utilization of PSA as an endpoint.
Yeah.
And, the PARP inhibitors have a pretty pronounced effect on rPFS, pretty pronounced effect on objective radiographic responses. But the PSAs are a little less impressive. These are not the hormonal agent. It's not Abby and Enza. No. So when you put the PSA in the context of the rPFS, and the majority of the progressions were actually PSA, then it caused me to wonder whether or not they were a little bit too quick to pull the plug. Now, that's one possibility. Fred, I think you had another idea, and I don't know if you want to share what you said to me
I
before
think
the meeting.
it's all hypothesis, right? I mean, they didn't use the full dose. I don't know if you need a full dose. I don't know if we can compare PARP inhibitors, if there are differences in efficacy. It's all hypothesis. But I think the decision was pre-planned for a futility, and they went ahead with stopping. And I think Tia made the comment that maybe they stopped too early, and maybe they should have continued, because they stopped at 200 patients. So relatively small group, 100 in each. Yeah.
All right. We're going to have our last module, Dr. Agarwal.
Very perplexing results. Still digesting. So I was told to just complete all novel treatment strategies for metastatic prostate cancer in 10 minutes.
Yeah.
And I was like scratching my head. That was like last month. We saw presentations today, which took the whole afternoon, all about novel therapies. So I requested Dr. Bryce if I can just wrap up immunotherapies and AKT inhibitors, and he kindly approved. So we'll just talk about immune checkpoint inhibitors, and there had to be a focus on cabozantinib plus atezolizumab trial. So I will focus on that Cosmic 021 trial results, which led to an ongoing phase 3 CONTACT-2 trial, and we'll basically touch upon AKT inhibitors. So this is more like a forward-looking talk rather than about the agents which may be available in the clinic in the near future, but none of them are available right now. I took 53 seconds already explaining that. So this is my lifetime disclosures. I don't do 1 year, 2 year, 3 years. So this is everything I have taken from any drug company for consultancy and research in my lifetime. Always safe, rather than be sorry, right? So let's look at the cabozantinib atezolizumab combination. This was a phase 1 Cosmic 021 trial, where it was probably the largest phase 1 trial ever done. 750 patients, 30 different tumor cohorts. Prostate cancer was one of them. And then because based on the promising data, that has gone to CONTACT-2 trial, which is phase 3. I'll also touch upon other novel combinatorial regimens, which are promising, and then we'll look at AKT inhibitors. So let's look at these data, which I presented in ESMO meeting in Paris a few months ago. We know cabozantinib is already approved for metastatic RCC. All of us are experienced with, as far as using cabozantinib is concerned. And now with approval of nivolumab combination with cabozantinib, we also are used to dealing with the side effects of TKI plus IO. But in prostate cancer, it's still novel. And the rationale for combining these two agents is that cabozantinib promotes an immunopermissive environment, which may allow PD-1, PD-L1 inhibitors to be more active. Now, this hypothesis is already validated in kidney cancer field, but it still is being tested in prostate cancer. So based on these rationale, a phase 1 trial was started, and we enrolled 30 patients in prostate cancer cohort after establishing the dose of 40 milligram cabozantinib. And based on encouraging data in 44 patients, which I presented in GU ASCO in 2020, we expanded the trial to 132 patients. Primary endpoint was investigator-assessed objective responses, and a important eligibility criteria was that patients had to have progressive measurable disease before they could enter the trial. This is a unique and a very stringent inclusion criteria, which is a part of this clinical trial. And there are several other objectives here, endpoints, which you can see here. And so this, I'm coming directly to the primary endpoint, objective responses as assessed by the investigators. We saw 23% objective responses in patients who are all comers. Patients had, and these patients had to have measurable disease. So pretty much all patients had measurable disease, but then if you look at visceral and extrapelvic lymphadenopathy, so patients who have mediastinal lymphadenopathy, who had axillary lymphadenopathy, anecdotally, we know these patients have more aggressive disease. So we decided to look specifically in those patients who had visceral or extrapelvic lymphadenopathy. So here are the results in front of you. 23% objective responses in all comers, and 27% objective responses in patients who have more, we call them high risk or extrapelvic disease, measurable disease, 27%. We also did the blinded independent radiology assessment, which was a post hoc analysis. The objective responses went down in both cohorts, but disease stable, if we call it disease control rate, which combine objective responses and the stable disease rates, they are pretty much same. Very impressive, 80% plus disease control rates. And median duration of response is around 7 months. So these patients are responding, they're responding for good time, period. And time to objective response is quick. So 1.7 months as assessed by the investigators. So let's look at the waterfall plot. And this gave me more pictorial view of how responses are. And we can see majority of patients are responding. So based on this, and again, let's look at the progression-free survival. This is a radiographic progression-free survival in a patient population who were progressing at the time of entry in measurable disease. So 6.8 months in high-risk patients, extrapelvic visceral metastasis, and otherwise it was close to 6 months. These are PSA responses. Whenever I see PSA responses in prostate cancer, I tend to think the combination is effective. Most of the treatment-related side effects were driven by cabozantinib. We can see here diarrhea, fatigue, nausea. There were adverse events which were immune-related. 17% patients required high-dose corticosteroids. But please remember, when the trial started, we did not have experience with dealing with diarrhea on cabozantinib when patient is also receiving atezolizumab. And it was mandated by the protocol that we have a low threshold for using steroids to make sure we don't let patients develop bowel perforation if by any chance they are having diarrhea because of immune checkpoint inhibitors. So even though diarrhea were happening because of cabozantinib, more patients were likely to get high-dose corticosteroids. With that, we have started this CONTACT-2 trial. This is open in 27 countries right now, and we hope to finish accrual next year. And this trial is randomizing patients to cabozantinib plus atezolizumab versus an alternate NHT, which seems like a standard control for all the trials which are recently presented. And these patients cannot receive more than one NHT in the past. So if somebody is progressing on abiraterone, they can be randomized to cabozantinib plus atezolizumab versus enzalutamide and vice versa. Primary endpoint is radiographic progression-free survival. Let's move on to the other combination regimens. We can see they are quite promising regimens, nivolumab plus ipilimumab. Again, very similar responses, but please note that in the ipi-nivo regimen, almost 50% patients had TMB high tumors. So we know with the data especially presented in ASCO today by my mentee, Nicola Saig, who is in the audience, the TMB high patients, they respond in an unusually good fashion to immune checkpoint inhibitors. So 71% measurable disease rates, very comparable population. We see good responses, but then they have TMB high population. And there is hopefully, we'll see approval of nivo-ipi for TMB high patients down the line. But so far, these are the data. Pembrolizumab enzalutamide combination, another promising combination. And we can see here 39% patients had measurable disease. 17% patients had visceral metastasis, which is half of what we saw with COSMIC-021 trial. Still, I think the combination remains, has the potential to get approval, and we are looking forward to the final data of the phase 3 trial. The third combination did not pan out, the trial was negative, which was atezolizumab with enzalutamide versus enzalutamide. So this combination is likely obviously not going to be approved for our patients. With that, these are the two very promising technologies, options, which may become reality in our clinic down the line: BiTE antibodies and CAR T cells. Again, both are using the rationale that if you can train your T cells, either you train the T cells in the form of like CAR T cell, make them recognize the T cell antigen which is present on the prostate cancer, such as PSMA targeting CAR T cell, or some other antigens which are being tested in a clinical trial, or you create an antibody which can engage a T cell against a antigen which is being expressed on the prostate cancer. Both are very promising regimens or all technologies which are in early phase trials, and we are really hoping one of them will pan out or two of them will pan out. AKT inhibitors, 40 to 50% patients have functional deficiency of PTEN, which leads to over-reliance on AKT. So AKT gets upregulated. We saw this trial, ipatasertib plus abiraterone versus prednisone, and prednisone versus abiraterone. This was a phase 3 trial in patients who have newly diagnosed metastatic CRPC. This is a rationale. There is an interdependency between AKT pathway and the androgen receptor pathway. So there is a solid rationale for using this combination in our patients who are maybe unselected or selected. So these are the results. This was the study design. Large study which randomized patients to ipatasertib abiraterone versus abiraterone plus placebo. We saw the rPFS was significantly positive, almost 2-month improvement in patients who were PTEN deficient, but not in all-comer patients. Interestingly, if you look at it, this is a post-hoc analysis in front of you. If you measure PTEN loss by NGS, the survival benefit with the combination was even more pronounced. So again, provocative data, and we'll see how it is going to pan out down the line. And this is a phase 3 trial which is testing another AKT inhibitor, capivasertib, plus abiraterone versus abiraterone plus placebo in a hormone-sensitive setting. So this trial is ongoing, and I think with these combinations, we will see at least some of these combinations panning out and be available in our clinic in next 1, 2, or 3 years. But bottom line is, we need to keep identifying new molecular targets and biomarkers of response to improve our patients' lives. Thank you very much.
Very good. All right, we have 2 quick questions, and we've got about 3 minutes to get through them here. Very quickly, have you offered or would you offer a checkpoint inhibitor-based treatment to a patient with MSI stable mCRPC outside of a protocol setting? Fred, you said I haven't, but would for the right patient. Who is that patient?
Well, those few patients with an MSI high, but in Canada, even this approach, we can get reimbursement. So patients come in, would like to be tested, but it's just not a reality. But I think it would be interesting in those patients, and I think the few patients that we've seen respond have a certain phenotype that suggests they might respond. But I guess they're much better experts in this field than I am.
Dr. Beltran, who's the patient you would treat?
I've treated patients with high TMB, and for, I've used the cutoff of 10. Prostate cancer, obviously, it's quite variable, and those cutoffs are not well defined. I've treated a CDK12 altered patients before, and then mismatch repair mutations, even if they don't have MSI. Those are the ones I would have to say, though, I've had patients respond to immunotherapy without any of those things on clinical trials. And so we still, need to learn more about biomarkers.
Yeah, I agree. Oliver, do you have a thought there?
I agree with Bisha. I perfectly agree.
It's usually a safe bet. It's been my experience. All right. Based on the current clinical trial database, if the combination of atezo and cabo were available today for patients with mCRPC, would you recommend it? You can see there's a fairly even split here. Oliver, what's your thought?
I think we're going to have a whole series of new therapies within this space. And, we have VERU-111. We potentially have the enzalutamide. We definitely have the trial called PSMA-4 with PSMA lutetium. So, and then, of course, have the opportunity for chemotherapy. So I'm not quite ready to jump because I'm looking at the landscape and I want to understand the landscape better before I'm going to jump on any particular therapy. So I'm not quite ready to endorse it, particularly prior to having more data. It's an interesting subset of the measurable disease that neurologists have been looking at. But I'm going to look at the totality of data, look at the landscape, and then I'll make decisions.
Here's my friend. Last word on this?
Again, I'll wait for the results of the trial before endorsing it,
Fair enough.
Why what?
I have your answer right here. You said yes.
We have a clinical trial open in our clinic, So
I'm
Fair
still
enough.
digesting.
All right. Thank you very much, everybody, for attending tonight. It's been a pleasure spending the evening with you.